Good afternoon, everyone. My name is Tom Mazahery. I am an orthopedic spine surgeon at OrthoVirginia. We have offices throughout the state of Virginia. We have offices in Lynchburg, Virginia Beach, Richmond, and throughout the Northern Virginia area. I am specifically at the Reston office, and I take care of all the spine issues, ranging from cervical issues that we're going to talk about today, to lower back issues, thoracic issues, scoliosis, deformity. So any issues of the spine, that's my area of expertise. If you have any concerns from an orthopedic standpoint, please go to OrthoVirginia.com. That's our website. We have surgeons that take care of all body parts from an orthopedic and musculoskeletal standpoint. All right, so today's talk, we want to talk about pinched nerves of the neck. It's a tricky topic for some reasons, and there's some debate on disc replacements versus fusions, and so it's one of the big questions that I get in clinic on a daily basis. And so I wanted to kind of go through what the options are and why we're thinking the way we are. And some people come in wanting to have one and end up having another, and so it's a confusing topic. Let's start with the diagnosis. So the number one thing with any surgery, any procedure that you do, the right surgery for the right indication for the right patient as well. And so we want to make sure you got the diagnosis right, you got the right patient, you've ruled out all the extraneous things that could be pitfalls, and we'll get you to the right spot. So a pinched nerve typically presents with pain in the back of the neck. It goes typically to the back of the shoulder blade, and it radiates all the way down the arm. And it usually goes into the different fingers depending on which nerve it is. So the C5-6 nerve goes typically into the index and thumb, and the C7 goes into the middle finger, and the C8 comes into the last few digits. It can be very confusing, though. Sometimes shoulder pathology can present as neck pathology and vice versa. So one of the things that we do before we even go down the road of treatment options is to kind of confirm a diagnosis. And as any of my patients will tell you, we spend a lot of time making sure it's not the shoulder, because obviously you don't want to go be 3-4 months down the treatment options and you've been treating the wrong diagnosis. So in general, people who have shoulder issues, it'd be a shoulder arthritis or rotator cuff tendonitis, just in general, obviously there's a lot of differences here. They don't like doing above head activities. They don't like putting their coat on. It hurts when they're going to reach behind their back. They don't like reaching across their arm. So it's motions of the shoulder, motions of the arm that causes pain. Typically with a pinched nerve in the neck, there's pain in the shoulder, but it's in the back of the shoulder, and it radiates all the way down the arm with numbness and tingling. And those people actually like to put their arm above their head. It makes it feel better. It takes the pressure off the nerve a little. So it's almost when I walk into a patient's room and they have their hand above their head and they're talking to me like this, it's a big sign that the pinched nerve is the diagnosis. So we confirm the diagnosis with x-rays and see how much arthritis there is, how much of it is bone spurs and disc fragments, and then what's the global alignment of the neck. And then we get MRIs, and MRIs confirm, is there a pinched nerve that matches the symptoms? I'm going to pause there for a second, because anybody above the age 40 is going to have some degenerative findings on their neck. And so if you get an MRI of anybody above age 40 or anybody, personally, there's a very high likelihood you'll find something. Again, the hardest part of what we do is try to figure out, is the MRI findings, the radiographic findings, consistent with your symptoms? And if it's not, then again, we got to back up and do some more investigative work. And that could range from working on the shoulder to getting some of our other colleagues involved to possibly getting some nerve testing to kind of see is the nerve show that is angry enough. So again, we spend a lot of time on the front end making sure that the back end, once we go into the treatment options, then we got happy customers. So once we have the diagnosis of a pinched nerve, then the options are basically fourfold. You could give it time. Some of the pinched nerves calm down by themselves. It depends on if it's a soft tissue disc herniation or a bone spur, to doing physical therapy, which gives it time and strengthens the muscles, to injections in your neck, And along with all of those options is medications, anti-inflammatories, steroids, and other things to calm down the irritation of the nerve. Once you've exhausted those options, once you've done given it some time and it's not getting better, and you've tried medications, and you've done physical therapy, you've done injections, then you start talking about the surgical stuff, which is kind of where I want to spend the next 5-10 minutes on the surgical options of fixing the neck. So we will be taking questions on Facebook Live, and so we will go through some of the more common questions, but obviously this is a very much a gloss over, and there's a lot of nuances of what I'm about to tell you guys about disc replacements versus fusion operations. So hopefully this presents itself nicely. So this is a model of a neck. So what you can see is each vertebrae are labeled with one number. So these are the vertebrae, and the stuff that you see between it, the cushioning between the bones, are the discs. And the nerves come out on the sides, and the spinal cord's in the middle. So each vertebrae has basically 3 joints. There's a disc in the front and 2 facet joints in the back. Okay, the facet joints, we call them the knuckles of your back of your neck. And so the reason I bring this up is it makes a huge difference what these guys are doing and whether we need to talk about a fusion versus a disc replacement. Okay, so again, disc in the front, nerves come out on the sides, and facets in the back. So if you do indeed have a pinched nerve, the surgical options are we could either go from front of the neck and take out the disc and take the pressure off the spinal cord and take the pressure off the nerves. And that is the workhorse of our procedures. 90-95% of what we do is from front of the neck because it's more minimally invasive. All we have to do is cut the skin and everything else moves out of the way. There are some risks of swallowing, difficulty, and hoarseness, but that's transient and most of the time it gets better. When we go from the back of the neck, you have to move around some muscles or cut some muscle, which makes it more painful and also makes the recovery a little bit more. But from the front, typically what we do is we come to the front of the neck, and hopefully this projects well. And you can see that we take out the disc, clean up the nerves that come out of the sides. And once we've done that, that's the surgery. The surgery is cleaning up the nerves. So the indication for this is if someone has a pinched nerve, coming all the way down their arms, and we take the pressure off of it, at that moment they feel fantastic. But you have a hole where you've taken out the disc to get to the nerves. And the reason, again, we like to go from the front is more minimally invasive, but when you get to the nerve, you take the disc off of the nerve without touching the nerve. Versus if I go from the back of the neck, sometimes when I go from the back of the neck, I have to shave a bone, take the pressure off the nerve by moving the nerve so I can irritate the nerve. And if you don't fuse it in the back of the neck, it can collapse down further, and so it can pinch the nerve again. So although you can do what we call a laminar phragmotomy from the back of the neck, it is less often used than going from the front of the neck because this is more tried and true and it works better and the long-term results are better. So the number one procedure that we do is an anterior cervical discectomy and fusion. And it is one of the most successful surgeries that we do in spine surgery and all of orthopedics altogether. It works, it's minimally invasive. In recovery room, 90-95% of patients, the arm pain is gone. Numbness and tingling takes some time, but it comes back around, and weakness, if there was associated weakness, gets better sometimes soon enough. We can do this as an outpatient, depending on neck size and how many levels we do, or we can keep you in the hospital one night just to watch for your airway or risk of swelling. But again, it's the workhorse of what we do. Now, it's a 97% successful operation. But why would we want to do something different? Well, we look for long-term outcomes. One of the things that we've seen with this surgery is that when you fuse someone's neck, the levels above and below, there's a 25% chance in most studies, there's different numbers, 25% chance that at some point in your life, you have to come back and address the levels above and below. So adjacent segment degeneration is a big problem with any fusion surgery. So about 15, 20 years ago, we said, okay, well, what if we didn't fuse the neck? What if we came in and did a disc replacement? And there's lots of different disc replacements out there, but I'm just going to show you some common ones. And basically, you can see a disc replacement is it keeps the motion, And so it becomes you've taken the pressure off the nerve. The indications are exactly the same. You failed conservative management. Your nerve is still pinched. You go from the front of the neck and take out the disc, clean up the nerves, and now you need to put a spacer in there. And what if the spacer held this position and kept motion? As you can see, there's motion still preserved here. So lots of companies came out with different implants of what kind of implants to put in. And so 10, 15 years ago, we thought that by doing this, we would prevent that adjacent level degeneration. And the data is still, I did my first disc replacement in 2000, I believe 10. So we've been doing this for at least 12 years. I actually think it was 2008, so probably I think 13, 14 years that I've been doing this. And we've done hundreds and hundreds of this, and so has the community. The community obviously has done United States, thousands and thousands. And so when we look at the data 10 years out, we thought by this point it would be hands down, there it is, we did the disc replacement, so now we have a less likelihood of adjacent level degeneration. Well, in the process, we found some things. So number one, 10 years out, some data shows that yes, we're decreasing that percentage from 25% to maybe 10, 15%. But it's not every level. It's not every study. And some studies actually have shown that it's the exact same rate. So here we are, we did a disc replacement, we preserved the motion, and the next level was degenerating in patients at about the same rate. So it kind of tempered our enthusiasm for it a little bit. So we thought, oh my God, here we are, the fusion is going to be a thing of the past. And as a guy who was very much one of the first ones to do this replacement in this region, I was a big, big believer in it. And I'm still a big believer in it because I think it has some pros. But the cons are, well, maybe we're not preventing that next level degeneration. And I've had multiple patients where I did 10 years ago, did one level disc replacement. And despite that, preserved the motion, they did fantastic. But 5, 10 years later, they came back with another disc herniation. And so I've done an adjacent disc replacement on top of an old disc. So one of the things that we found in this 10 years of doing this is that, well, there's some pros and cons. Remember the facet joints that I was talking about in the back? So if someone has facet arthritis, as well as disc issues, and they have pinched nerves, and we start doing a disc replacement, the facets that are moving actually too much, we're preserving the motion, so we can actually exacerbate your neck pain. So it ends up being that we have to pay much more attention when we're doing a disc replacement is how pristine are your facets? And if they're really nice, well-preserved facets, you're a great candidate for a disc replacement. But if there's significant arthritis and bone spurs coming out of that, I can make you worse, or I can give you temporary relief by doing a disc replacement. And then you'd have to come back 5 to 10 years later because the bone spurs are grown back now from other areas. Furthermore, the implant, it's a movable implant. So the question is, adjacent level that we thought we were going to have a significant decrease of next surgery hasn't panned out just yet. And we're still trying to figure out if there's better data out there that tells us, hey, is this a superior study? We have not proven that it's a superior implant. But what we also found is that there's a little bit of an increased risk of having to go back in and taking care of the index level. So if I did a C5-6 fusion, the chance of going back in for that is actually less than 1, 2, 3%. Because fusions, we know how to make a fuse. We've been doing that for decades, and they heal just fine. But when we do a disc replacement, and unfortunately we revise a lot of disc replacements from people coming from all around, hopefully not from our own, but a lot that are either poor indications or poorly done. And so you got to make sure that disc replacement is done for the right indication. The arthritis is not there, the disc is not too collapsed. And number 2, you got to make sure it's done well. And the ones that's well positioned right off the bat during surgery, it holds beautifully, and most of them last. But we're starting to find that they're at the index level, where in the fusion, you have to go back in 1, 2, 3% of the time. At this level, for disc replacements, you got to go back in maybe 5, 6, 7% of the time. It's still not a large percentage, but it's double the percentages of a fusion. So it gives us pause. Now here I am. I want to make sure that I prevent the next surgery at the next level. But if I got to go back in for the same level, obviously that's not a happy customer also. So one of the things I tell my patients is I don't care who you go to or what you do, but make sure that it's done for the right indications. And the right indications, you got to make sure there's no facet arthritis. You got to make sure that how many levels are involved, which we'll come back to. And then most importantly, you got to make sure that the surgeon you got is going to spend more time than he ordinarily would with a fusion, because this takes more meticulous carpentry. When you're in there, you got to make sure that the implant is placed perfectly, and you can't just slam it in and leave out, which unfortunately can lead to bad outcomes. I don't want to show x-rays here, but I've had some patients come in with it's crooked. It's sitting like this. I've had some of them that were subsided, and so to revise that is a bigger deal. The other question is, which is the best implant? As you can see, the one I'm showing here is very mobile. So we still haven't figured out the perfect implant, although all of them work. All the ones I'm about to show you have good success rates. So we know that the success rate of this is high because when you unpinch the nerve, the indications of it are good. Of note, a cervical disc replacement is very different than a lumbar disc replacement. Very different indications, very different outcomes. In general, lumbar disc replacements are done for back pain, versus cervical disc replacements are done for arm pain. We typically don't want to do neck surgery for neck pain because it doesn't work very well, especially if you do a disc replacement and if you have neck pain, because you preserve the motion, you can actually make your neck pain worse. So you do the disc replacements for arm pain, nerve pain, with very little neck pain. So this is another implant. Again, you can see that it's a very squishy implant and works very different. It's kind of an all-in-one, but it works more as a shock absorber versus the other one was allowing a lot more motion. Okay, there's implants that have all metal on metal and have screws in the front that hold it. Then you can see there's no plastic on the inside, and there's ones that are a kind of hybrid of that, where it has a little squishiness, has some motion, but certainly less mobile than the first implant that I showed you. So all of these have their pros and cons, and biomechanically, we have not found a superior implant type yet. The rates are about the same, all of them work, and they work very well. So who's a good candidate for a disc replacement? The FDA has approved disc replacements for 1 or 2 levels in most implants. Each implant has a little different indications. So 1 or 2 level disc herniations in someone who has a soft disc herniation and or some bone spurs around it that don't have much arthritis in their facets. There's no gross instability, and they're young, and that number changes every year. So the older I get, the younger the age becomes. That number becomes, if your person is 1 or 2 levels, disc herniations, a disc replacement is a good option for you. If someone is in their 70s or 80s and they have a lot more facet arthritis, a lot more compression from bone spurs, and a lot more collapse of the disc, and they have 4 levels involved, that's not a person that responds very well to a disc replacement. That person needs a fusion and needs more stability in there. And so they both are equivalent outcomes. In the short term, the reason you do the disc replacement is what happens in the long term, what happens 5, 10, 15 years down the road. So people say, oh, is it more minimally invasive to do the disc replacement? Absolutely not. Same level of invasiveness, they're both relatively minimally invasive, both can be done outpatient, both wake up with your nerve pain gone. The question is, what's going to give you the longevity, excuse me. And what happens 5 years from now, 10 years level at the index level, and what happens levels above and below. So those are some of the major things that we talked about. And we also look at patients and what their pathology is and which of these type of implants. So the reason I showed you some of these is because we've used all of them. And so some people come in and they want metal on metal, and some people want the other ones. And so we talk about what the pros and cons of that. One of the last things I want to touch on is the consequences of an imaging in the future. So in orthopedics, we don't like to use any implants that you can get an MRI in the future. MRIs are a workhorse of getting imaging and being able to diagnose pathology. And so most of these disc replacements do create an artifact at the index level. So if I do a C5-6 and there is a problem behind that implant, it's very hard to diagnose it on an MRI sometimes. Different implants have different things, and different radiologists use different MRI protocols to try to counteract that. And so we have some ways to get around it and get less of what we call a scatter on the MRIs. But sometimes you got to get a CT myelogram to diagnose if there's a problem behind it. So if someone has severe cord compression, I'm not a huge fan of using disc replacement for that area, because if I need to be able to image the cord afterwards, it's not the best implant for imaging afterwards. So that also goes into our thought process. You can use it for someone who has a pinched nerve or spinal cord compression, but if someone has terrible cord compression, it usually goes away from that. And lastly is obviously if someone has instability, so if they have what we call spondylolisthesis of their neck, or facets that are incompetent, this is not a good implant for that. So I'm going to stop there, and I'm going to see if there's any questions to take. And hopefully we've given you there's a lot more to that. There's a lot more data that we can get into and get into the weeds, but I think that gives you an understanding how surgeons think about disc replacements versus fusion surgery. If both excellent surgeries, you will have excellent outcome after both surgeries. The question is what happens 5, 10, 15 years afterwards.
Thank you so much. We do have a lot of questions that have come in. So our first question is, do you use nerve conduction studies before doing cervical spine surgery?
Depends on how vague the diagnosis is. Sometimes the diagnosis is very clear, and someone is getting worse in front of us, so we don't want to get them to surgery and fix them. And sometimes the diagnosis is very vague, or I need to figure out if that previous surgery is how much is chronic, how much is acute. So yes, we have Dr. Amanda Truxas with us that does the nerve conduction tests. So we very commonly use EMGs and nerve conduction velocities to figure out what's going on. And then during surgery, it's standard of care in this region to do neuromonitoring during surgery also.
Thank you. Do you ever do a hybrid surgery and include both a disc replacement and a fusion in the same surgery?
Absolutely. It is one of our things. I didn't talk about it much because it's outside of FDA criteria for most implants. And so just today, I just signed up a person for that exact scenario. And I think I told him to watch this, so he's probably out there watching this. So we oftentimes, if the implant's only approved for one level, or if someone has multiple levels that they need, it's actually a very good surgery to do a fusion at one of the levels. And we like to fuse the lower levels to create a stable base. And then either the top level or the top 2 levels. And I've done it in multiple different ways, where I've fused the bottom and done 2 disc replacements above, or I've done 2 level fusions and done a disc replacement above that, or any of those constructs. It works very well. And again, all of these surgeries work very well in the short term. In the long term, the ones that I've done a hybrid construct actually have done beautifully, and I haven't had any that had major issues or any issues.
Thank you. Do you use robotics in your surgeries?
So robotics is a big thing that we use at Reston Hospital. We have actually a couple of different robots here, and one of the ones we have that we like the most is the Mazahery robot. It's very fancy and it's great, and we use it for both minimally invasive and open complex deformity cases. The robotic surgery is typically for the thoracolumbar spine, and in the cervical spine, especially anterior cervical spine, it's overkill, so you usually don't need it. When you go from the back of the neck, so a little more reconstructive work, some of the stuff that we've done where I was showing you here, yes, sometimes we use either navigation or robotic surgery to do that, and we've done both of those, but you don't need it for the front of the neck, and you don't need it for disc replacements because the anatomy is very different in that area. But robotics is a big part of what we do in the thoracolumbar spine.
Thank you. Do you decide on the type of surgery you're going to do before you're in the OR? Or do you ever change what type of surgery you're doing when you're in the OR?
99.999% is done before the OR. So it's just called shared decision making. Obviously, we present the data to the patient. We look at the MRI, we look at the EMGs, and we put all the data together. What are the goals of the patient? What are my goals? And so we come up with a treatment plan. And so once we go into surgery, it's either I'm doing a disc replacement or a fusion of the probably, again, 300 plus, 400 plus that we've done of these type of surgeries. There's been one patient that went in for a disc replacement, and we had to fuse. That person knew before that, so any disc replacement, you have to be able to have a backup plan if the disc replacement is not fitting in well for some anatomical reasons. So if we change a plan during surgery, you tell the family members, you tell the significant others before you do it. So there's no surprises when you wake up. Everything is decided before surgery.
Thank you. If a pinched nerve can heal on its own without surgery, how long do you give it to heal before you know that surgery is needed?
Depends on how bad the symptoms are. So most pinched nerves get better between 6 and 8 weeks. And so we usually give it at least 6 to 8 weeks to kind of see the ones that are going to calm down by themselves. If someone is just in pain, and I don't mean to say that in a way, someone has 1 or 2 out of 10 pain, and they say, yeah, it's just a nuisance in my life, you can give it months and years, as long as it's just pain and there's no deficits. If someone has weakness and they can't lift their arm, or their bicep doesn't work, or their shoulder doesn't work, so that one you want to move sooner, because the longer you wait on weakness, the more likely it becomes permanent. Now, you don't want to rush in too much, because some of that resolves itself also. So there's a fine line of being aggressive and fixing it so that you don't have permanent deficits, versus letting nature do its thing and let things resolve. And then the rest of it is the numbness and tingling. And so it depends on how it's affecting people's lives, how much it's affecting their work and home life, how much pain they're in. If someone's 10 out of 10 pain and they have a gross weakness of their arm, we're going to move sooner to do the surgery than if someone has 6 months of 1 out of 10 pain and it just happens when they do some strenuous activity.
Thank you. Someone says that they have a fusion scheduled in several weeks. Until then, do you have any recommendations for stretches or things that they can do when their neck pain is intense?
So what we find is that in spine in general, necks also, but in general, when you exercise, when you get your heart rate up, it changes your physiology, and it gets oxygen to those muscles, and it gets oxygen to the discs. This is part of the reason they degenerate, is they inherently have poor blood supply. So when I tell patients to exercise, I want them to exercise because we know the data is when they exercise, when they do anything, is better than when they do nothing and when they're sedentary. So I don't care if you run or bicycle or swim or anything that gets your heart rate up. Go for a long walk. Go for, everybody's got a different activity level. Like a 20-year-old has a very different thing that they want to do versus a 80-year-old. But we want you to get your heart rate up to get oxygen to those areas. In general, if someone has a pinched nerve, hyperextension of their neck and lateral rotation to the side is what activates it. So I tell patients to avoid those type of activities. But get your heart rate up and exercise, because all of that helps get your symptoms under control.
Thank you. Do pinched nerves in the neck cause numbness in the shoulders, arms, hands, and fingers, and aches when bending your head forward?
They can, absolutely. I mean, the most pinched nerves present with all of those symptoms that they just mentioned. So pain typically in the neck, the shoulder blades, all the way down in your arms, numbness and tingling in your hands. Again, sometimes numbness tingling from some other areas, from the brachial plexus, from the cubital tunnel, from the carpal tunnel. So you got to make sure that it fits what the patient's symptoms are and what their radiographic signs are and what their physical exam signs are. And so if you lean forward, depends on where the pathology is. Absolutely, there's things that when you lean forward, it makes it worse. But in general, most pinched nerves get worse when you hyperextend your neck. But I've had plenty of patients that get worse when they forward flex.
Thank you. Someone says that they had 2 surgeries, a fusion and a disc replacement in their neck over 14 years ago. And this year they're starting to get pain in the back of their neck and upper back. Would that be connected, and what should they do?
Absolutely go see your physician. I mean, that is, go see an orthopedic spine specialist, because this is exactly the issue. Is here someone who has 14 years ago had symptoms, got resolved. I assume that he or she's been good for 10, 14 years. And now they're having new symptoms. So what is that symptoms coming from? It could be their shoulder. Could be a rotator pathology. It could be not related at all. It could be just pure muscular symptoms. It could be that the next level, the levels that aren't fused or have a disc replacement, are having now arthritis. So adjacent level degeneration is setting in. Or it could be that the index level, either the disc replacement is shifting or moving, or the fusion never took. So lots of things can be going on, but it starts with a good physical examination and a discussion with your doctor and some imaging. Obviously, so starting with an x-ray.
All right. Thank you so much. We are out of time. If we did not get a chance to answer your question live, we will answer it later in the comments. Dr. Mazahery, would you like to close?
Yeah, so thank you very much for joining us. Obviously, the key takeaway from this is that if you have a pinched nerve, if you have these symptoms, go see your physician. We have offices at OrthoVirginia throughout the state, and we have spine surgeons throughout the state that can take care of you. So seek guidance from a professional who knows these things, and this is what they do for a living. And disc replacement versus fusion, you will do well. Either both are good options. It's a discussion between you and your surgeon.